Welcome to this series of videos on communicating with chronic pain patients. This is Module 5, Motivational Interviewing, Stop Convincing and Start Evoking. Have you ever had a conversation like this? You tell a patient with chronic pain, you really need to start exercising more. And the patient responds, I know, but whenever I exercise, my pain gets worse. So you explain, actually, exercise is one of the best things you can do for chronic pain. The patient says, I understand, but I'm afraid I'm going to make things worse. So what do? We give them more information. We explain the research. We explain the benefits of exercise. We explain pain science. We explain why movement is safe. And after 5 minutes of explaining, the patient says, I understand everything you're saying, but I'm still not comfortable exercising. Sound familiar? The problem may not be that the patient needs more information. The problem may be that we're trying to convince them. And that's where motivational interviewing can help. Motivational interviewing, or MI, is a collaborative communication approach designed to help people explore their own motivations for change. And there's an important distinction here. Motivational interviewing isn't about giving someone motivation. It's about helping them discover the motivation that already exists. That matters in chronic pain because patients are often ambivalent. Part of them wants to change, but another part is afraid. A patient might say, I know I need to start walking again, but every time my back hurts, I think I'm making it worse. Both sides are real. I want to walk, and I'm afraid to walk. Our instinct as clinicians is often to argue for the first side, but motivational interviewing asks us to do something different. Get curious about both. In motivational interviewing, there's a concept called the righting reflex. Healthcare providers see a problem, and naturally we want to fix it. The patient says, I haven't been doing my exercises. Immediately we think, you need to do your exercises. The patient says, I'm afraid to move. We think, movement is safe. The patient says, I don't think physical therapy is going to help. We think, let me explain why physical therapy works. We're trying to help. But there's a fascinating problem. The harder we argue for change, the more the patient may argue against it. Imagine I say, you really need to exercise. The patient responds, I've tried exercise before, and it made things worse. I say, but you probably weren't doing the right exercises. The patient says, no, I've done physical therapy 3 times. Suddenly look at the roles we've created. I'm arguing for exercise, and the patient is arguing against exercise. That's exactly the opposite of what I want. Motivational interviewing tries to reverse those roles. Instead of telling the patient why they should change, we ask questions that allow them to tell us. For example, if you were able to become more active again, what would that allow you to do? The patient might say, I'd love to start walking with my wife again. Now, who just made the argument for becoming more active? The patient did. We might follow with, what do you miss most about those walks? And the patient says, honestly, it wasn't even the exercise. It was our time together. Now we're no longer talking about sets and repetitions. We're talking about something the patient values. That's powerful. In motivational interviewing, we call statements like these change talk. Change talk is when the patient expresses their own desire, ability, reasons, or need for change. Listen for phrases like, I'd like to, I wish I could, I probably should, I used to be able to, I know I'd feel better if. These are openings. Imagine a patient says, I know sitting on the couch all day probably isn't helping me. Don't immediately respond, exactly. That's what I've been telling you. Instead, get curious. What makes you say that? Now the patient might tell you, because I've noticed that the longer I sit, the harder it is to get moving. And you might reflect. So part of you is starting to wonder whether avoiding movement might actually be contributing to the problem. Now the patient is making the case for change, not you. Here's a simple change you can make tomorrow. Before giving advice, consider whether you could ask a question instead. Instead of, you need to start walking. Ask, what kind of activity would you like to get back to? Instead of, you shouldn't be afraid of movement. Ask, what concerns you most about becoming more active? Instead of, you need to do your exercises more consistently. Ask, what do you think gets in the way of doing the exercises? That last question is particularly important. Maybe the patient isn't lazy. Maybe the program takes 45 minutes. Maybe they're exhausted after work. Maybe they don't understand why they're doing the exercises, or maybe every time an exercise produces pain, they believe they're causing more damage. You can't solve the right problem until you understand the actual barrier. There's another small MI technique that can dramatically change the tone of a conversation. Ask permission before giving information. Instead of, let me explain why pain doesn't necessarily mean damage. Try, would it be okay if I shared something about pain that might help explain what you're experiencing? It's a tiny difference, but it communicates autonomy. You're saying you're part of this conversation. And after providing the information, don't simply keep talking. Ask, what do you make of that? Now you're back to listening. Motivational interviewing has increasingly been studied in musculoskeletal pain. A 2025 systematic review and meta-analysis examined motivational interviewing for adults with musculoskeletal pain. The overall findings suggest that MI may be useful for some pain-related outcomes, although the results vary depending on the outcome, condition, and intervention, and we need to be careful not to oversell it. Another 2025 systematic review specifically examined motivational interviewing combined with exercise for chronic low back pain. That review found insufficient evidence that adding MI improved pain, disability, or physical function. That's an important reminder. Motivational interviewing isn't magic, and it isn't a replacement for appropriate clinical care. Think of it as a communication tool that may help us address something clinicians struggle with every day. Ambivalence about change. Here's a simple sequence you can try. Ask, reflect, evoke. First, ask an open-ended question. What would you like to be able to do that pain is currently stopping you from doing? Then reflect the answer. So getting back to gardening would make you feel like you're getting part of your normal life back. Then evoke their reasons for change. What do you think would be a realistic first step toward doing that again? Notice who's doing most of the thinking. The patient. That's intentional. When a patient isn't changing, our instinct is often educate more, explain more, persuade more, convince more. But sometimes the patient doesn't need another argument from us. They need an opportunity to hear their own argument for change. So resist the writing reflex. Get curious about ambivalence. Ask open-ended questions. Listen for change talk. Ask permission before providing advice. And connect behavior change to something the patient actually values. Because the goal isn't to convince the patient to do what we want them to do. The goal is to help the patient discover why change might matter to them. Sometimes the most motivating voice in the room shouldn't be ours. It should be the patient's.